This lecture is about cardiac arrhythmias. Some of it will be a review for you, and some of it will be new to you because you're looking at it through a different lens as an advanced practice nurse. I have included some ECG strips for you to see the different arrhythmias. So we know that they are electrical abnormalities of the cardiac conduction system that can vary in severity from trivial to life-threatening. They can occur in the presence or the absence of cardiac disease. And they're really put into two categories, rate and location. And tachycardia is above 100 beats per minute. Bradycardia is less than 60. Location is either ventricular in the ventricles or supraventricular above the ventricles. Arrhythmias can arise from any conductive tissue. Symptoms are mostly related to ventricular rate and the severity of underlying heart disease, if there is any. And you'll see that again, that ventricular rate is really, it really drives the arrhythmia. Definitions and epidemiology. Let's just look at a few of these. I want you to go over them in detail. You do need to know that greater than 50% of cardiac arrhythmias arise from the atria. AFib and aflutter and other supraventricular attacks occur frequently with that ST elevated MI. Look at that number, 80 to 22%. Afibrillation is the most, or atrial fibrillation is the most common arrhythmia, over 2 million Americans. It's a little more prevalent in men, and it's definitely more prevalent after age 60. And ventricular tachycardia really predisposes to sudden cardiac death, about 300 to 400,000 annual deaths in a year in the U.S., and most of those deaths occur in older adults. 80% of deaths that are from VFib in the context of ischemic heart disease, so those people that are dying in that 300,000 to 400,000 experience VFib, and that's related to their ischemic heart disease. There are structural anomalies, congenital rhythms that I want you just to look at, and in particularly knowing that the younger population experiences unexplained deaths because of those reasons. VTAC and VFib are a common cause of outpatient cardiac arrest after a STEMI. And then just review those reperfusion arrhythmias. They're quite interesting. After procedures and people have been reperfused, they're more likely to have a cardiac arrhythmia. Now we'll look at bradyarrhythmias. That's really results from abnormalities between the SA node, the atrium, the AV node, or the intraventricular conduction pathways. Idiopathic fibrosis, major cause of AV block, particularly in the elderly, and I want you to review these other reasons, all the way from hypothyroidism to neoplasms, and pay attention to those meds. The calcium channel blocker and the beta blockers can be responsible. Then when we look at the bundle branch blocks, we do really recognize they can be intermittent or chronic, symptomatic or not, and you just really have to look at the underlying cause. Right bundle branch block is associated with right ventricular hypertrophy, ischemic heart disease, PE, several causes. Review those. Left bundle branch block is associated with ischemia, MI, aortic stenosis or regurg, and dilated cardiomyopathy and Lyme disease. A bundle branch rhythm doesn't always require treatment, but identifying and managing that cause and treating the symptoms is really crucial. The pathogenesis, there's two functional components of the cardiac conduction system, and we subdivide those. One into the impulse generating tissue, that's that SA and AV nodes, and then the impulse propagating tissue, the His and the Purkinje fibers. And then the third, the SA node, we know is the natural pacemaker of the heart, but if it's stimulated, suppressed, or blocked, it will induce a tachyarrhythmia or a bradyarrhythmia. And really, you know, when you talk about a sixth sinus rhythm, really that SA node's not doing its job. It's just not relaying that message. So cardiac arrhythmias are a result of an abnormal impulse, formation, or conduction in categories, and those are abnormal automaticity, triggered activity or re-entry. And that helps us understand those ECG strips when we understand what provokes these arrhythmias. Clinical presentation. For the tachyarrhythmias, the patient's really symptoms are due to those ventricular rates. Also the extent of underlying heart disease, ventricular function, and other precipitating factors. Palpitations are the most common symptom they're going to present with, and you have got to drill down about their past cardiac disease, arrhythmia history, all that's relevant, family history, and really their coronary artery disease risks. Tachyarrhythmias tend to shorten the diastole and compromise ventricular filling. Doesn't that make sense? Decreased the blood pressure, the cardiac output, and the coronary perfusion. The patient will often complain of lightheadedness, dizziness, syncope, shortness of breath, or fatigue. And interestingly, fatigue is the most common symptom in AFib reported. A serious tachyarrhythmia may result in hemodynamic decompensation, causing hypotension, chest pain, heart failure, change in the level of consciousness, or even sudden cardiac death. Contrastly, the bradyarrhythmias are going to either cause symptoms or not. It might just be found incidentally on an ECG. Symptoms related to the ventricular rate has to do with metabolic demand and underlying cardiac disease. So there's two types. There's absolute, where the heart rate is greater than 60 beats per minute, and there's relative, where it is too slow to even maintain normal blood pressure or cardiac output, even if it is less than, greater than 60 beats per minute. And I have that opposite. The absolute is less than 60 beats per minute. Symptomatic bradycardia is really related to, can present as frank syncope or near syncope, transient dizziness, lightheadedness, or confusion. The patient might present irritable, with some lassitude, inability to concentrate, apathetic, forgetful, and palpitations if the bradyarrhythmias manifest from a sick sinus syndrome. So persistent brady really makes the person feel fatigued. They have reduced exercise capacity, heart failure, lethargy, weight gain, changes in skin, hair, nails, constipation, eyelid edema. And that, when you see that whole battery of symptomology, you really have to include in your differentials hypothyroidism. Could be the cause. Physical exam, you're going to evaluate vital signs and include orthostatic blood pressure measurements. You're looking particularly at mental status, diaphoresis, respiratory effort and anxiety, and hydration status. Evaluate the neck vessels and pulses, the thyroid gland thoroughly. Chest needs to be inspected, palpate, and auscultated. And review on page 517. It's very in-depth. So diagnostically with cardiac arrhythmias, we're going to always get a 12-lead ECG. The lab is usually CBC with DIF, CMP, a comprehensive metabolic panel, include a magnesium, TSH, and possibly toxicology for stimulants. Cardiac biomarkers when we're looking for ACS and coronary ischemia, an echocardiogram, radiographic imaging, looking at that cardiac silhouette in the chest x-ray, and stress testing. There are some other diagnostics that come with more thorough workup that include Holter monitor, event monitors, loop recorders, tilt table test, electrophysiologic studies, and you can read some of the other diagnostic tests. Differential diagnoses. These are the ones I want you to look at to be familiar with. Under the tachyarrhythmias, it's the sinus tach. I want you to look at WPW. I want you to look at atrial fib, flutter, ventricular tachycardia. Under the bradyarrhythmias, look at that list. I want you to understand sinus brady, AV blocks, first, second, and third, bundle branch blocks, right, left, and hemi blocks. And that's just important for you to be familiar with. Management, it's really individualized, okay? With the tachyarrhythmias, two conditions to use anti-arrhythmic medications are when it's potentially life-threatening arrhythmia, or they're hemodynamically unstable or symptomatic. Okay, so there's 4 classes of meds we use, class 1 through 4. To review those on page 524. Now, I also want you to look at that information on atrial fibrillation and A-flutter, looking that we really try to maximize rate control and prevent thromboembolism, and how we do that is patient-specific. VTAC has got to be identified, and we have to treat the underlying cause. Under bradyarrhythmias, we're really evaluating if they're hemodynamically stable, and we are investigating the causation and trying to correct that. Referrals, of course, we know as nurses, hospital if unstable. These patients are referred to the cardiologist. They might be referred to an electrophysiologist, cardiologist. Patient and family education is just vital. They have got to understand the nature of the particular arrhythmia. If it's benign, it might reduce their fear. But if it's potentially serious, a really frank discussion of the problem and treatment options. Lifestyle modifications are a big part of our education, uses and side effects of the antiarrhythmic meds. You've got to educate in depth about pacers and ICDs if they have those implanted. And one thing we know is that there is going to be a better outcome if the patient is CPR certified and there is a emergency plan that's been created and they understand. Thank you very much.